Good evening, everyone. So, we are continuing our lecture series on discussing various connective tissue disorders, and this week we'll discuss very briefly the EULAR guidelines for lupus erythematosus. So, this was the post Diwali lecture, and I had a little less time this time. So, I wanted to tackle a very small topic, and we'll quickly go through what are the EULAR guideline recommendation for lupus erythematosus. These are the 2013 guidelines. Okay. So these are the latest guidelines that we have. The last I think came in 2019, and in 2013 EULAR published an updated version of those guidelines, and we'll just look at the points that EULAR says and how to guide while treating a patient of lupus erythematosus. Clear? So without much further ado, let's start our discussion on EULAR guidelines for lupus erythematosus. So EULAR guidelines had an update in the year 23. There are five overarching principles. That means the five principles or five major statements made in the EULAR guidelines that we have to take care of. And then there are 13 recommendations regarding treatment. So EULAR gives five principles that we have to take care of while treating a patient of SLE. It tells you about what are points to take care, what are the points that you have to keep in mind while evaluating a case of SLE. Okay. In 13 recommendations, EULAR guidelines gives you the recommendations about what treatment modality to be used, whether you should continue treating with HCQ, methotrexate, mycophenolate mofetil, or you should go into belimumab, anifrolumab, or rituximab, cyclophosphamide pulses. So these are the recommendations or 13 recommendations given in the EULAR guidelines. The focus in the 2013 update is on the early use of combination therapies and a good focus on lupus nephritis. Remember, lupus nephritis is the most dreaded complication of LE, and in any case of evaluation of SLE that you are, any patient of SLE that you evaluate, you need to keep in mind that you are keeping an eye on the kidney function. You should always have an knowledge about the proteinuria or any kind of kidney dysfunction in a patient of LE. Okay, the moment lupus nephritis sets in, you have to make sure that the treatment is appropriately catered while targeting the kidney function also. So make sure that the level of the action of kidneys, the level of protein loss through urine have to be kept in mind. So this is the most important thing that the EULAR guideline recommends, or EULAR guideline focuses on. Okay, so without much further ado, let's start our discussion on EULAR guidelines. Now, there are five overarching principles that EULAR tells you to keep in mind. The first is multimodal management. That means a patient of SLE has to be treated by different specialties, which include rheumatologists, nephrologists, and dermatologists. And this is why understanding LE is very important. We are a part of team that helps a patient of SLE. Okay, the moment the kidney dysfunction sets in, nephrologist has to be on board. The moment the inflammation is too intense to lead to serositis or synovitis or arthritis in SLE, you need to keep a rheumatologist on board. So whenever you admit a patient of SLE, make sure that you have consultations from the nephro department and the rheumat department. Okay. The SLE activity has to be assessed at every visit. Every visit, you have to assess what is the activity of SLE, even if it is quiet down post treatment. So you have to use various measures or various, criterias or scales or grades to grade what is the activity of SLE at every clinical visit. Organ damage has to be assessed every year using instruments. So there are various instruments available on the internet. You can go ahead and read about them, and you have to use a validated instrument so that you can assess what is the activity of SLE at that given point of time. That helps to keep track of the disease activity, and even if, let's say, the patient changes their domicile, changes, goes to some other state, and some other dermatologist is not taking care of them, they should know what was the activity of LE beforehand. Okay. The third principle is that non-pharmacological interventions, which include sun protection, stopping smoking, a healthy balanced diet, regular exercise, bone health promotion, or taking care of bone health resorption and absorption, all the non-pharmacological, non-medicinal interventions have to be kept in mind. They are proven to improve long-term outcomes, and these interventions have to be counseled or have to be told to every patient at any stage of disease. So even if the disease is very much severe and you're giving strong treatments, strong pharmacological treatments, the benefit of non-pharmacological intervention has to be told to the patient and made sure that they are being continued. Clear? The fourth principle is that the pharmacological interventions have to be very patient and disease specific. For example, you have to keep in mind the patient characteristics, organ involvement, treatment side effects, additional comorbidities, what is the risk of damage to internal organs, and what are the patient preferences. So, all of these factors, and more than these factors, the patient specific criteria has to be developed, patient specific treatment modalities have to be established and used. Okay, so non pharmacological to every patient, but pharmacological have to be changed, tailored, and altered as per the patient characteristic. They have to be tailored as per disease specificity also. If the disease is active or disease is intensely or severely inflammatory, the treatment should also reflect that. Your treatment should be adequate as per the disease activity. In fact, EULAR guidelines, we'll discuss them a few slides afterwards, that EULAR guidelines also recommends different drugs for different severity of disease like mild, moderate or severe. Okay. Early SLE diagnosis, regular organ involvement screening, prompt treatment, and strict treatment adherence are very essential to prevent flares and organ damage and improve prognosis and enhance quality of life. Now, the fifth overarching principle is that the earlier you diagnose SLE, the earlier you make a record of organ involvement and damage, the earlier you start the treatment, the more you make sure that the treatment is being adhered to, it's being followed properly. These are very essential principles to prevent flares and organ damage. Clear? Let's move forward. Hi. Hope you're enjoying this video. I know it's a long video, so I thought I'll give a certain break after listening to such a long videos that I make. If you think that these videos are helpful in your residency, do consider becoming a member. You can opt for Sapphire membership or Ruby membership. I would prefer it to be a Sapphire membership, of course. Um, you get access to longer videos, bonus contents, extra information to make things more interesting, and to cover each and every aspect of the topic that we are discussing. Okay, so I think that's enough of a break. I should continue with the video, and you should listen to the other person at the bottom right corner tell you different topics of dermatology, venereology, and nephrology. That being further said, let's continue with the video. Now, slowly, we'll discuss all the 13 recommendation as per EULAR. Okay, in the square brackets, you will see the level of evidences and the grade of recommendations. Okay, you can go to the internet and find what all 2B or 1 or C or A or D mean. You can go, it's given easily in the Google search. So these are the level of evidences and the grade of recommendation for each and every recommendation. So let's start with the first recommendation. The first recommendation is that HCQ for all patients. You have to give HCQ, or you are guided to give HCQ to every patient. The target dose to be achieved is about 5 mg per kg per day, not exceeding 400 mg per day. Clear? HCQ has to be given to all patients unless contraindicated. Dose has to be modified as per patient and disease activity. So as per patient and disease activity. Before starting HCQ, it's better to have a baseline evaluation, baseline ophthalmic evaluation. Okay, baseline ophthalmic evaluation to keep in mind about any corneal opacities and the retinal function. So these are two side effects of HCQ that to keep in mind: corneal walled opacities and retinal function. So you should have a baseline value before starting HCQ. Most of the time in clinics, we don't have access to baseline evaluation. So we start HCQ, but make sure that you get it done as soon as possible so you have something to compare with. And then every year or annually, you should get a baseline evaluation. Annually you should get an ophthalmic evaluation to look at the retinal function and to look at the corneal opacification. Keep in mind the disease flare. If the disease is severe, don't keep the patient only on HCQ. Add other drugs also. We'll discuss other drugs in subsequent slides. Now the blood levels, if available, you can do it, but it's too impractical to do. So EULAR 23 guidelines says that it's not necessary to do blood levels to calculate the dose or to look at the dose of the HCQ. You start HCQ and look for the clinical response. It is not recommended as per EULAR 23. Let's move forward. The second recommendation is that keep steroids minimum. So keep steroids at the lowest dose possible to control disease activity. The dose is based on the type and severity of organ involvement. Reduce steroids to maintenance dose of less than 5 mg per day prednisolone equivalent. Now what do we mean by that? You start the steroid dose as much steroids you require to control disease activity. So you can start a patient on 40 milligram, 60 milligram, 80 milligram depending on what is the disease activity, but the effort should be to taper it down to minimum less than 5 mg per day prednisolone equivalent. Okay, but even if you want to taper it down, make sure that disease doesn't flare up. Clear? The disease has to be controlled in less than 5 mg per day steroid equivalent. Clear? As soon as possible, as soon as it is possible to withdraw steroids, withdraw them, stop them as soon as possible. In moderate to severe disease, you may consider giving IV steroid pulse. So we are talking about oral steroids less than 5 mg per day. 5 mg per day. These are oral steroids. But if the disease is severe, you can consider IV methylprednisolone pulse about 125 to 1000 milligram per day for 3 consecutive days. So that has been suggested by EULAR. In fact, in India, if we want to use DEXA, then we can use DEXA pulses also, or DPs. Okay, so we can use them when the disease is severe, but our effort should always be to taper down steroids gradually and keep it at the minimum less than 5 milligram per day and stop them as soon as it is possible. Let's move forward. You may add other drugs if there is no response to HCQ plus glucocorticoids, or you are unable to reduce the severity with glucocorticoids. Now, what do we mean by that? If you give a patient HCQ or glucocorticoids plus minus glucocorticoids and you are not able to control the disease activity, add other drugs. Or if you have started steroids, you are able to control it, but the moment you reduce, there is a flare up. That means you need to add another drug. Now, what are those other drugs? As per EULAR, the drugs recommended are methotrexate, azathioprine, and mycophenolate mofetil, because a lot of different kind of studies are available comparing these efficacy of these drugs. Okay, there are other drugs, for example, leflunomide. Okay, leflunomide or thalidomide. These all drugs have been used and they significantly control disease activity, but you don't have comparative trials as much to recommend their usage. So EULAR guideline focuses more on methotrexate, azathioprine, and mycophenolate mofetil. Other lines that can be used are biological agents. These include belimumab and anifrolumab. So anifrolumab has been recommended by or approved by FDA for treatment in 1921. So that's why EULAR has now included anifrolumab in the disease armament. Okay, let's move forward. In case of life or organ threatening disease, when organs are threatened, you can add IV cyclophosphamide or rituximab in refractory cases. So you start with HCQ, glucocorticoids plus minus, and if that is not working, you go for second line immunosuppressive drugs or biologicals. If that is not working, go for IV cyclophosphamide pulse. Another recommendation is of rituximab, which can be used. There are studies which show that rituximab and cyclophosphamide given together have unconfirmed benefits, so it's not recommended to combine these two modalities together. If still no response after cyclophosphamide pulse and rituximab, you can consider modalities like plasma exchange, stem cell transplantation, CAR cell therapy, or any other experimental therapies for LE. Clear? So that's only at the end when you are not able to control it by different drugs, you can consider these kind of experimental modalities. Clear? Let's move forward. The fifth recommendation is that if you have active skin disease, if you're not able to control skin disease, you have to first of all, while treating skin limited or skin involvement in LE, you start with topical agents. Now, topical agents include potent glucocorticoids. So you have to use potent to suprapotent glucocorticoids. Remember, while discussing glucocorticoids, we said that we have to make every effort to reduce the dose and withdraw as soon as possible. If the disease can be controlled by using topical drugs, control it by topical drugs. Other topical sorry, other topical modalities are the topical calcineurin inhibitors like tacrolimus and pimecrolimus. Okay, so consider that as topical modality. You have to include anti-malarials as systemic drugs. The choice is hydroxychloroquine, but you can use chloroquine also. Systemic glucocorticoids if needed. So if disease is still not controlled by HCQ and topical agents, you give systemic glucocorticoids in case of active skin disease. The second line drugs include anifrolumab, belimumab, methotrexate, and mycophenolate mofetil. So the lower two are non-steroidal immunosuppressive drugs. I think I will not use the word NSAIDs. I will use non-steroidal disease modifying agents. Okay. And the first two are biologicals, anifrolumab and belimumab. We have discussed them in the member-specific video in SLE. So if you know how they act, mention that in the comment section and I know that you have seen that video. Let's move forward. The sixth recommendation is when you have active SLE along with neuropsychiatric disease. So if you have active SLE and it's very inflammatory, you give glucocorticosteroids along with immunosuppressive agents like mycophenolate mofetil or methotrexate. Remember, these drugs are slow acting. Methotrexate is a very fast acting drug, takes about 1 or 2 weeks. But azathioprine is very slow acting, it takes about 6 to 8 weeks. So keep that in mind. In case of neuropsychiatric disease, you need to control inflammatory activity as soon as possible. So give glucocorticosteroids, which are the fastest acting immunosuppressive agent. Okay. Other drugs that can be used are cyclophosphamide and rituximab if you want to control the inflammatory manifestations. If there's a history of atherothrombotic events or you have antiphospholipid syndrome, APL is antiphospholipid syndrome or any evidence of atherosclerotic or thrombotic events, you have to add antiplatelet agents like ecosprin or aspirin or anticoagulants like rivaroxaban. Okay, so you need to add them if there's an evidence or any history of atherosclerotic events. Clear? Let's move forward. Good evening everyone. I hope you're enjoying this video and I've come again to ask you to vote for Delhi for Dermacon 2028. So with the support of IDBL Delhi State Branch, do vote for Delhi and come and meet all the dignitaries here and let's have a good academic discussion in the backdrop of the cultural heritage that Delhi offers. So enjoy this vibrant city that I duly call my own and if you follow this instruction to become an e-voter, you can just easily vote on the IDBL website. It hardly takes less than a minute and it's better to vote as early as possible. Will help you in tackling all those spam calls that you get. So make sure that you choose Delhi as a good venue in 2028 and let's meet there. I shall see you in Delhi. Bye bye. The seventh recommendation is when you have existing autoimmune thrombocytopenia in a patient of SLE. So SLE has different systemic manifestation. One of the hematological important manifestation is acute severe autoimmune thrombocytopenia. And the definition is about less than 20 to 30,000 per ml. These are the platelet counts. So if the platelet counts go less than 20 to 30,000 per ml, you consider that as acute severe autoimmune thrombocytopenia. If that is present, give high dose glucocorticosteroids, either systemic orally or via pulse. You can add to it IV immunoglobulins. You can add to it rituximab or high dose IV cyclophosphamide pulse. So the regimen says that glucocorticoids alone or add IVIG or add rituximab or add high dose cyclophosphamide pulse. When you control the disease activity, you maintain it by using rituximab, azathioprine, mycophenolate mofetil or cyclophosphamide. So either a biological which works on B cell function or a non-steroidal disease modifying agents. Clear? If the treatment is not controlling the disease properly and the thrombocytopenia is still not controlled, you may consider splenectomy or thrombopoietin receptor agonist in case of refractory disease. So this is the last line of defense as of now. Clear? Let's move forward. The 10th recommendation is in patients who have high risk of renal failure. Now, what are those high risk? How do you judge if the patient has high risk of renal failure? If the glomerular filtration rate is reduced, if it's low, if there are cellular crescent on biopsy, if there is fibrinoid necrosis on biopsy, or if there's severe interstitial inflammation on biopsy. So if any of these features are present, then the patient is said to be at high risk for renal failure. In that case, you have to start on high dose IV cyclophosphamide along with IV glucocorticosteroids if required. So the drug of choice or the recommended drug as per EULAR is IV cyclophosphamide pulse. So you can give daily IV cyclophosphamide, but the pulse form works better. In fact, one of the important indications for IV cyclophosphamide pulse is SLE. You may add GCS like we add in the DCP regimen. So you can have IV cyclophosphamide pulse, or you can combine it with DEXA as an IV DCP pulse to control in patients of high risk renal failure. Keep that in mind that you have to look at kidney function at all times. Kidney dysfunction, no, kidney function. Kidney function at all times. Make sure that you keep an eye on it. Okay, let's move forward. The 11th recommendation is what to do when SLE is in remission or controlled with treatment. You gradually decrease the dose of treatment very slowly over the course of, let's say, decreasing doses every 2 to 4 weeks. In fact, there is a supplementary document to EULAR guidelines which is freely available on the internet, and you can find that what is the speed of at which you have to reduce the doses. Clear? Make sure that you withdraw glucocorticoid first. So steroids have to be reduced and then stopped first. So you stop first glucocorticoid, then you stop the other immunosuppressive like mycophenolate mofetil, methotrexate, azathioprine, etc., or any biologicals which are there, and then you maintain on HCQ. You maintain the patient on HCQ and then gradually decrease the dose and then stop. Clear? But make sure while you are decreasing the drugs, the non-pharmacological interventions, the non-pharmacological interventions keep continuing in the patient. So make sure you keep continuing these interventions. Clear? Let's move forward. So let's summarize the 13 recommendation as per EULAR. Okay. So these are the recommendations. HCQ for all patients, keep steroids minimum, add second line drugs, make sure that you treat adequately in life-threatening or organ-threatening disease, make sure that you treat properly in active skin disease, in active SLE or neuropsychiatric disease, in autoimmune thrombocytopenia, make sure you treat properly lupus nephritis and prognosticate when to stop treatment, at least 3 years on immunosuppressive drugs. Make sure you treat people who have high risk for renal failure. What to do after remission SLE, gradually taper, stop steroids first, then other DMARDs. In SLE and thrombotic antiphospholipid syndrome, add anticoagulants, add aspirin. In immunization and other consideration like bone health screen for malignancies. So these are the 13 recommendations as per EULAR 2023. Okay, let's move forward. So this is the URL for the EULAR guidelines. I'll put the URL in the description. You can copy paste it and look at the EULAR guidelines 23 and read it in detail. So if you're liking this video lectures, I would request you to consider becoming a Ruby member. But remember, I would like to discontinue Ruby membership in the coming months. And if you think these videos are helpful in your residency, do consider becoming a Sapphire member of the channel. The options to become a member will be there on the channel homepage. You can go there and click on the join button. The Sapphire membership gives you access to longer videos with additional content and exclusive polls to decide newer topics. With that, I'll finish this week's lecture on EULAR Guidelines and Recommendations 2023 for treatment in LE. It is very important if you want to treat a case of SLE in wards, or if you want to give vivas on LE, or if your long case or short cases happens to be LE. So you need to have an understanding of the EULAR guidelines and their recommendation when to give what and what all drugs have been recommended. Now remember, these are guidelines. These are there to guide you. You can make decision as per the disease specificity and as per the specific patient specific characteristics and preferences of the patient. The treatment can be modified in all instances as long as you are taking care of the patient, as long as you are taking care of the inflammation. Okay, with that being said, I'll finish this week's lecture before it touches 40 minutes. Adios and bye bye.